Good afternoon, dear students. Today we will discuss a very important topic, very difficult topic, concerning interstitial lung disease. I would like that you to learn how to listen to patient, to colleagues, and hear the diagnosis. If we hear interstitial lung disease, we should understand that lung interstitial is a primary target in the pathology of this category of disease, of interstitial lung disease. I would like to refresh your knowledge concerning lung interstitial. Lung interstitial is defined as a continuum of loose connective tissue throughout the lung composed of three subdivisions. First, it's so-called bronchovascular axial, surrounding the bronchi, arteries, and veins from the lung root to the level of respiratory bronchi. Second, is the parenchymal acinar, situated between the alveolar and capillary basement membrane. And third is the subpleural lung interstitium, situated beneath the pleura as well as in the interlobular septum. Lung interstitial in normal case is not visible radiographically and becomes visible only in case of pathology process, including edema, fibrosis, tumor, scarring, which lead to increase its volume and attenuation. In this slide, you can see the acinar parenchymal lung interstitium between the basal membrane of membranes of alveoli and capillary beds. Image itself, is this interstitial enlarged, changes quality of this loop interstitial. It's lead to damage of gas exchange. Finally, it lead to respiratory failure. So interstitial lung disease, it's very heterogeneous group of disease, including of a lot of disease which different etiology factor, pathology, clinically, and different approach to treatment. In this slide, you can see the first group, it's interstitial lung disease of non-associated, including connective tissue disease associated with interstitial lung disease, drug, interstitial lung disease as a side effect of consumption of some kind of drugs. First of all, for example, amiodarone. And interstitial lung disease and as a result of occupational hazard exposure. Second group is the so-called granulomatous interstitial lung disease, which characterized by formation of specific or non-specific granulomes, is along interstitial, including sarcoidosis, hypersensitivity pneumonitis, and, by the way, known etiology of granulomas, including tuberculosis. And today we will pay great attention to idiopathic interstitial pneumonia. This also group of diseases with unknown causative factor, unknown origin. We will say about it later. And miscellaneous interstitial lung disease, including pulmonary lung organs, histiocytosis of lymph angiomatosis. So, idiopathic interstitial pneumonia. Also, it's a heterogeneous subset of the broader category of interstitial lung disease, characterized by unknown etiology. Common histological feature is distortion of lung interstitium by highly variable combination of inflammation and fibrosis. It's a very important thing that, to know ratio between inflammation and fibrosis, because some of idiopathic interstitial pneumonia, like idiopathic pulmonary fibrosis, have got only fibrosis. For example, non-specific interstitial pneumonia. There are at least 3 morphology phenotypes, including prevalence of inflammation and of prevalence of fibrosis. It's very important to know because the effectiveness of our treatment and our treatment, prescribing treatment, should be directed for this this main mechanism of pathogenesis. For example, if we have patient have got only fibrotic process, we should prescribe anti-fibrotic drugs. If patient have got inflammation, the first choice of drug is anti-inflammatory drugs. Other things, if you prescribe, in the case of interstitial pulmonary fibrosis, anti-inflammatory drugs, it's lead to ineffectiveness of therapy, fail of our therapy. So, according to Revised American Thoracic Society and European Respiratory Society classification of idiopathic interstitial pneumonia, now we have several groups of interstitial idiopathic pneumonia, including chronic fibrosing interstitial pneumonia, including idiopathic pulmonary fibrosis, approximately 50% among all idiopathic pulmonary, idiopathic interstitial pneumonia. Idiopathic non-specific interstitial pneumonia, 25%. Next group is smoking related, including respiratory bronchiolitis, interstitial lung disease, approximately 10%, discriminative interstitial pneumonia, and acute or subacute interstitial pneumonia, including cryptogenic organizing pneumonia, acute interstitial pneumonia, and rare idiopathic interstitial pneumonia, including idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchymal fibrolastosis. Sometimes when we obtain the clinical results, obtain the lab investigation, instrumental investigation, and including high-resolution CT scan biopsy, it's very difficult to classify these concrete clinical forms of idiopathic interstitial pneumonia. That's why we have right to make diagnosis unclassifiable idiopathic pneumonia, unclassifiable idiopathic pneumonia. So we start with idiopathic pulmonary fibrosis. It's defined as a chronic fibrosing interstitial lung disease, unknown etiology, that occur in adults and characterized by histopathological pattern of usual interstitial pneumonia. That's why IPF or usual interstitial pneumonia is the same definition, but in 10 edition of International Classification of Disease, you can find IPF. Usual interstitial pneumonia have relation to histopathological or rheumatological pattern of this disease. That's why if rheumatologists write down the conclusion, this changes on CT scan look like the usual interstitial pneumonia, or have got a usual interstitial pneumonia pattern. It means the diagnosis of idiopathic pulmonary fibrosis is confirmed. Just once more about relation between IPF with IAP and interstitial lung disease. Prevalence 50% per 100,000 population, and practically absent in patient younger than 50 years of old. But among the persons who have more than 75 years of old, the prevalence is estimated at 0.2%. For my opinion, the pandemic of new coronavirus disease in future will get a great influence from prevalence of the IPF, and we can wait the dramatically increased the prevalence of IPF in future. But it's only my opinion, we should wait. Okay, problems of IPF, poor prognosis due to unresponsiveness to traditional therapy. Median survival for IPF is just 3 years. Many patients with IPF have got experience of acute episode of respiratory withering. It's called acute exacerbation, which have got a higher risk of death and significantly reduced of lifespan of this patient. Pathology stage of IPF, including predisposition, initiation, and progression. In case of predisposition, it's including genetic, exogenous exposure, hazard factor, aging, and which lead to damage of sometimes diffuse damage of alveoli. This lesion of alveoli not lead to inflammation. This alteration of alveoli lead to injury of alveoli, lead to activation of profibrotic factor. It's lead to activation of fibrotic process. For example, these cells produce very important factor like a tissue growth factor beta, like cytokines, which lead to recruitment First of all, fibroblast, and change the quality of loop connective tissue surrounds the alveoli. It's lead to, frankly speaking, it's lead to scarring of the, first of all, SNL lung interstitial. In this slide, you can find the inflammatory cytokines like tumor necrosis factor alpha or interleukins 1, 6, and other. But you can see tissue growth factor beta, and also growth factor for plates, for vessels, for endothelial, which lead to formation and change of quality of connective interstitial, connective tissue, loop connective tissue surrounding the alveoli. It's lead to development of, first of all, respiratory failure and other problems. Potential risk factor for IPF, including cigarette smoking and environmental exposure, microbial agents, gastroesophageal reflux, and genetic factor, for example, history of familial pulmonary fibrosis and other. So you should image the patient with IPF. It's patient, mostly it's men, as gender, more than 50 years of old, a smoker or ex-smoker, who have got such clinical signs like unexplained chronic exertional dyspnea. That's why it's a crucial clinical signs. Patient with unexplained chronic exertional dyspnea, and commonly present with cough, basilar inspiratory crackles, and finger clubbing. So progressive breathlessness and eventual respiratory failure are the most common natural history. Insidious onset of otherwise an unexplained dyspnea on exertion, basilar inspiratory crackles. It's dry or Velcro type. So I would like to show example this Velcro type of this basilar inspiratory crackles, typically for patients with IPF. Inspiratory, due to inspiration, you can hear during the auscultation these crackles and clubbing of the finger. There are three clinical phenotypes of IPF. First phenotype, a relatively stable variant, proceeding without exacerbation with slow progression. So this patient maybe have got a 5 or 7, no more, years of lifespan. And second phenotype, phenotype with frequent exacerbation, and phenotype with fast, steady progression. And separate phenotype, and its phenotype combination as this signs of IPM and emphysema, when pulmonary fibrosis mainly affected the lower part of the lung, and emphysema you can detect in upper lobes. So IPF diagnostics based on the clinical, radiographic, and morphological findings. By the way, if patient have clinical signs, we thought about it, and radiographic confirmation of usual interstitial pneumonia, we have all criteria for making diagnosis of IPF. If the pattern of usual interstitial pneumonia is not found on high resolution CT scan, we have no this confirmation. This patient should be directed to surgical lung biopsy. By the way, you should know that surgical lung biopsy is invasive procedure that cannot be done in many patients. ITC, American Thoracic Society and European Respiratory Society propose criteria for diagnosis of IPF in the absence of surgical lung biopsy. First of all, it's an exclusion of other known cause of interstitial lung disease, toxic effect, consumption of some kinds of drugs. I talked about amiodarone, and environmental exposure, connective tissue disease, abnormal results of spirography tests, including evidence of restriction. First of all, it's reducing vital capacity and forced vital capacity. And due to prevalence of restriction under the obstruction ratio between FEV1, which reflect to obstruction disorder, and to forced vital capacity. I told the evidence of restrictions. This parameter, forced vital capacity, reflect to restriction. This ratio increased. And also you can use the method, for example, to detect of impaired gas exchange. First of all, it's decrease partial pressure of oxygen in the arterial blood, or for example, it's a test for diffuse capacity for carbon monoxide. Bibasilar reticular abnormalities with minimal ground glass opacity. So reticular abnormalities should be more than ground glass opacity. And transbronchial lung biopsy or bronchial alveolar lavage show no feature to support an alternative diagnosis, age more than 50 years of old. Minor criteria, including insidious onset of otherwise unexplained dyspnea of exertion, duration of illness more than 3 months, and be basilar inspiratory crackles, Velcro type. In this spirography, you can see the typically spirogram and curve typically for restriction disorders. You can see, for example, forced vital capacity. In this column, it's percentage which predictable level, and the diminished forced vital capacity 55% from predictable level, and forced expiratory volume for 1 second 60%. You can see prevalence, the diminish of forced vital capacity under the forced expiratory volume, and this ratio in this case 83.9%. That's why it's prevalence, restriction under the obstruction. This patient have got a great history of smoking, but he complained for progressive dyspnea, and the IPF was confirmed by CT scan, and in this paragraph also confirmed about prevalence of restriction. By the way, this curve, like a patient eats like an X, also typically for fibrosis, the diminish of inspiration and expiration, diminish of lung volume restriction. And I would like to revise your knowledge, the pattern of radiographically interstitial lung disease and changes in lung interstitial lead to a different type of opacity. For example, if in case of edema, when lung interstitial enlarged due to edema, it's often accompanied by linear opacity, which can be visible in X-ray examination. Reticular, it's network. Reticular honeycombing, it's a small cyst. Nodular and reticular nodule. But for IPF, more typically reticular and reticular honeycombing. But typically, usual interstitial pneumonia pattern, it's a subpleural and basal predominance of this reticular and honeycombing changes, reticular abnormality. Honeycombing with or without traction bronchoectasis due to scarring process. It's lead to dilation of the bronchus, bronchioles, and absence of features listed as inconsistent with usual interstitial pneumonia pattern. For example, what no typically, it's prevalence of ground glass abnormality under the reticular abnormality, peribronchial vascular predominance, microdome nodules, discrete cyst, diffuse mosaic attenuation, trapping, and consolidation. Is not typically for pattern of usual interstitial pneumonia. In this slide, you can see subpleural and basal predominance, basal predominance of the reticular changes. And you can see also the cross section of the bronchi, which practically reach to from the root of the lung to pleura. It's tractional bronchoectasis, and you can see so-called apicobasal gradients. So in apex, it's practically absent changes and significantly increased prevalence of reticular abnormalities in the basal part of the lung. It's a very interesting so-called propeller symptoms. For example, we can hear and opposite this reticular chest, this propeller. Reticular abnormalities, honeycombing, you can hear his, but also this honeycombing have got a subpleural predominance. Honeycombing with traction bronchoectasis, also you can see the cross section of bronchium reach from the root to the peripheral part, practically subpleural localization cross section. You can see this bronchi. It's dilated bronchioles, bronchioles. And natural history of IPF. First CT scan, you can see reticular abnormalities, subpleural predominance, then increased, and in 36 months, it's lead to death patient due to fibrotic process in the lung. So histopathological criteria, but I would like to stress, we it's not for all patients. If, for example, we can't find the pattern of usual interstitial pneumonia in case of high resolution CT scan, we can recommend it lung biopsy. Other things we must make diagnosis after high resolution CT scan when we obtain the pattern of usual interstitial pneumonia. So, evidence of marked fibrosis, architectural distortion, honeycomb is predominantly subpleural, paraseptal distribution. Presence of patchy involvement of lung parenchyma by fibrosis. Presence of fibroblast foci. Absence of feature against a diagnosis of usual interstitial pneumonia, suggesting an alternative diagnosis. Is a histopathological criteria for. That's why, just once more, if you suspect IPF, we first of all, we should identify maybe causative factor. That's why if we find, for example, causative factor, for example, occupational exposure and consumption of amiodarone, we should exclude diagnosis of interstitial pulmonary fibrosis. If we exclude causative factor, we prescribe high resolution CT scan. If we obtain pattern of usual interstitial pneumonia, we make diagnosis of interstitial pulmonary fibrosis. If no, we recommend patient surgical biopsy. If we not meet with criteria of histopathology criteria of IPF, we exclude IPF as a diagnosis. So, selective features associated with increased risk mortality, level of dyspnea, and diffusion capacity of the lung for carbon monoxide, and less than 40% from predictable level. Desaturation less than 88 during 6 minutes walking test. It's very important, by the way, for all physicians, general physician, and pulmonologists, cardiologists have got this very cheaper devices. It's pulse oximetry. We can check the saturation of oxygen. For example, for me, it's 98%, up to 95. It's normal range. But sometimes we check these results during rest. But it's very important thing when we retest after, for example, physical exertion. For example, during 6 minutes working test. And if patient after this test, maybe after left upstairs for 1 or 2 level, we can check desaturation. It's a very high risk factor of mortality patient with pulmonary fibrosis. And extent of high resolution CT scan, pulmonary hypertension. You should know that it's so-called hypoxic vasoconstriction or Ehlers-Danlos syndrome, when we patient have got a hypoxia of alveoli and contraction of pulmonary arterioles, lead to pulmonary hypertension, lead to overload to right ventricle and right ventricle hypertrophy. And increased level of dyspnea, decrease of forced vital capacity more than 10% from absolute level, and decrease of diffuse capacity more than 50% from absolute level during, for example, 3 months of monitoring this patient. Also confirm about increased risk factor of mortality in this patient. And worsening of fibrosis on high resolution CT scan S2. So we make diagnosis of IPF. And also we should obviously make diagnosis of complication of the disease. First of all, it's chronic lung failure, because it's chronic process. About lung failure, we will discuss about this topic and the next lecture, during the next lecture. So what treatments work for improving condition this patient? First of all, it's oxygen therapy. If patient have got a lung failure, we should compensate drop of oxygen in the blood due to oxygen therapy. It may be long-term oxygen therapy using of oxygen concentrator at home condition, outpatient condition, or oxygen. So pulmonary rehabilitation, it's very important since it's not very simply, and pulmonary rehabilitation have got a high level of evidence for such things. But because it's a reversible process, in the end stage, we should think about lung transplantation. I told that esophageal, gastroesophageal reflux, it's also a risk factor for progression of lung fibrosis. That's why the means of this esophageal reflux using of proton pump inhibitor lead to improving condition of this patient. And there are two antifibrotic drugs. I've got a high level of evidence for treatment patient with IPF. It's pirfenidone and nintedanib. What treatment don't work for treatment for IPF? First of all, it's corticosteroid, immunosuppressor drug, including azathioprine, cyclophosphamide, and other. By the way, 2 decades ago, all patients with IPF were treated by using corticosteroids and azathioprine, cyclophosphamide. Until the multicenter clinical randomized clinical trials, Panther IPF. According to this treatment, one group patient obtained this triple therapy, including corticosteroids, azathioprine, cyclophosphamide, and acetylcysteine. Other group obtained placebo. And results of this treatment, patient who had obtained triple therapy have got the highest level of mortality, highest of respiratory mortality, highest level of exacerbation, comparing with patient which obtained placebo. That's why in case of IPF, these drugs don't work and please will not prescribe this drug. For treatment patient with IPF. Pirfenidone, according ASCENT trials, reduce loss of lung function, reduce loss of exercise tolerance, improve progression-free survivals. Pirfenidones, its mechanism of action, antifibrotic, it's a blockade of tissue growth factor beta, which crucial cytokines which support and accelerate fibrosis of the lung. And this schedules of treatment that, for example, after 3 weeks, patient used 3 capsules 3 times daily with food. But nintedanib, so trade name Vargatev, it's multiple tyrosine kinase inhibitor. Also, according to impulse trials, randomized clinical trials, reduce loss of lung function. Very important things, and which make a choice number 1 for treatment of patient with progressive fibrosis or IPF. Reduce time to first exacerbation, and dosing the 150 milligram BID every 20 hours with food. And adverse effects including diarrhea, vomiting, increase of liver enzymes, should be corrected by using of anti-diarrhea drugs, loperamide, metoclopramide, and if increase ALT/AST more than 5 times under the normal range, we should stop this therapy. And you should also check the creatinine level, and if patients have got glomerular filtration rate less than 30%, these drugs also contraindicated for treatment of this patient. And these clinical trials, you can see them that pirfenidone and nintedanib have great impact for diminish of chance of post-vital capacity. And in this slide, you can see mostly nintedanib diminish of acute exacerbation. It's very crucial. It's very important for treatment patient with IPF. Diminish of exacerbation, which potentially lead to death patient. Nintedanib can affect patient with stage 4 post-vital capacity in early stage of IPF, and in late stage you should prescribe S2 because patient with post-vital capacity less than 90% from predicted level also have great effect to breaking fail the respiratory volume. But so I would like to show this slide, and please look at this slide and make a conclusion. Is it IPF or not? Because you can see reticular abnormalities, cyst, honeycombing. But so it's no, because it's not, it's diffuse process. It's emphysema in patient with COPD, chronic obstructive pulmonary disease. But patient with IPF have got a such distribution, prevalence in basal membrane, this apical basal gradient, and subpleural mostly. That's why It's very important tools for making differential diagnostic of the disease. Okay, next clinical forms. It's non-specific interstitial pneumonia. Chronic interstitial pneumonia, we should make such diagnosis if we lack histopathological features of typical usual interstitial pneumonia, discriminative, and or other. The main change in all cases is an interstitial pneumonia characterized by expansion of alveolar septa by variably dense infiltrate, predominantly mononuclear inflammatory cells, which or without associated with fibrosis. That's why at a ratio between inflammatory cells and fibrosis. In case of IPF, it's fibrosis. In case of non-specific interstitial pneumonia, it's presence of inflammation. It's a very important thing because histologically it's a infiltration of mononuclear inflammatory cells, which produce pro-inflammatory cytokines. That's why it's target for anti-inflammatory treatment. The most important clinical characteristic that distinguish non-specific interstitial pneumonia for IPF, it's mostly it's subacute onset rather than incident onset of symptoms. In 1/3 of the patient associated with fever, a lack of strong male predominance. We told that in case of IPA, it's male predominance. By the way, it's non-specific interstitial pneumonia. Mostly it's for female, non-smoking female, and more younger than 50 years of old. And relatively absent of clubbing, increased frequency of feature suggestive connective tissue disease. By the way, if we detect accompany suggestive connective tissue disease, it's not primary, it's not idiopathic, non-specific interstitial pneumonia, it's secondary due to connective tissue disease. For example, often, for example, systemic scleroderma. And main rentgenology science, it's ground glass opacity, its prevalence under the reticular abnormalities. Decreased transparency of the lung tissue by the type of ground glass opacity, irregular linear fibrosis, compaction, fraction bronchobronchial ectasis. It also can happen in case of non-specific interstitial pneumonia. Thickening of the intralobar septa, which lead to reticular pattern, reticular abnormalities. A reduction of the volume of the lower lobes. Very rare consolidation zones. In most of patients, you can detect intrathoracic lymphadenopathy. Store subpleural trips with normal lung, stored lung tissue, subpleural sparring, so-called. In this slide, you can see patchwork quilt distribution of ground glass opacity. You can see the subpleural normal lungs is so-called sparring store lung tissue. And also you can see, what, by the way, practically absent consolidation. By the way, in the case of ground glass opacity, you can detect the lung architecture, lung structure in the areas of ground glass opacity. In case of consolidation, it's no visible any structure of the lung, vessels, no bronchus. In this slide, you can see also it's typically non-specific interstitial pneumonia. All patients with newly diagnosed interstitial lung disease on unknown origin are recommended serological tests to exclude connective tissue disease. These tests, excluding, for example, it's necessary CRP, seroactive protein for detection of level of systemic inflammation, anti-nuclear antibody panel for detection of connective tissue disease, rheumatoid arthritis, dermatomyositis, scleroderma, Sjogren syndrome, vasculitis panels. You should ask patient about occupational of home dust exposure, infection, and consumption of some drugs, because some drugs can lead to changes in the lung parenchyma, look like non-specific interstitial pneumonia. So, but if we detect ground glass opacity, in many countries, national recommendation make surgical lung biopsy. But you should know that 30-day mortality rate of lung biopsy is 70%, and diminish of diffusion capacity of the lung by carbon monoxide test less than 35% for predictable levels, also higher risk of death. In case of IPF, biopsy can lead to exacerbation. And but contraindication for patient with 60 years of age, and diminish of the lung diffusion test less than 45% of this. What about treatment? We recommended patient with non-specific interstitial pneumonia, if you exclude other causative factor, recommended systemic corticosteroids like prednisolone in dosage half and 0.75 mg/kg day, and starting dose, or cyclophosphamide, 2 mg/kg day, and but if we prescribe more significant dosage of prednisolone, for example, according to clinical trials, prednisolone 0.6 milligram for kg day for duration 7.7 months without dose reduction, it's accompanied with less relapse of disease. Mortality rate less than 10% after 5 years of duration. Of course, this non-specific interstitial pneumonia. And now we did discuss about 2 acute forms of idiopathic interstitial pneumonia. It's cryptogenic organizing pneumonia and acute interstitial pneumonia. So cryptogenic organizing pneumonia, which is the name applied to the idiopathic forms of organizing pneumonia, bronchiolitis obliterans, organizing pneumonia, is a distinct clinical entity with features of a pneumonia rather than a primary airway disorder. Cryptogenic organizing pneumonia is believed to be a consequence of alveolar injury and is characterized by formation of organizing buds of granulation tissue obstructing the alveolar lumen and bronchioles, resulting in respiratory failure. Organizing pneumonia is a pathologic diagnosis and can be secondary to an identifiable etiology. Cryptogenic organized pneumonia should be diagnosed only after exclusion of any other possible etiology. It's a very important since, for example, my experience when we see clinical and X-ray computer tomography signs of COP, we recommend patient plan biopsy. Patient was not agree to make this biopsy, and in 3 months, unfortunately, patient this term was under wasn't under the monitoring, medical monitoring. After 3 months, we changed diagnosis for lung carcinoma. That's why we should exclude as the causative factor which accompany with clinical and instrumental signs of organizing pneumonia. Clinically, cryptogenic organizing pneumonia present in the 5th or 6th decade of the life and accompanied by fever, malaise, cough, and shortness of breath. Often symptoms are subacute, weak in duration. Patients frequently fail empiric antibiotic therapy for presumed bacterial pneumonia because first diagnosis of such patient, if, for example, patient have a fever and changes in the X-ray, it's pneumonia, and fail empiric antibiotic therapy. Sometimes physician change, patient obtains several courses of empiric antibiotic pneumonia without any effect. Cough may be dry or productive, sputum may be or clear or discolored. Rare patient develop of rapidly progression disease with severe dyspnea and hypoxemia. Chest pain, night sweats, significant significant weight loss and mild arthralgia are uncommon symptoms. Hemoptysis and pneumothorax have rarely been reported. So in the areas of infiltration, you can, during expulsion, you can find bubbling rails, and in common blood analysis, you can find leukocytosis, accelerate erythrocyte sedimentation rate, increase C-reactive protein in the range from 20 to 40 mg per liter. And radiography, chest radiography findings, the chest radiograph findings in COP include patchy diffuse consolidation, which talked about, mostly involving bilateral lower zones. Other described findings including migratory, irregular, linear on nodular opacity, pleural effusion can also be seen. Higher resolution computer tomography reveals bilateral patchy peripheral localized consolidation on or ground glass opacity. They are often asymmetric. The classic high-resolution CT scan described in COP is the so-called Ethel science, also known as the reversible halo science. This science characterized by a dense outer rim of consolidation around the focal ground glass opacity. This science seen in about 20 patients with COP, and this symptom is not specific. It can be seen in various other infection or inflammatory condition I taught in case of tumor. So it's Ethel sign. This you can see dense outer rim of consolidation surrounding focal ground glass opacity. But sometimes in patients with COP, you can find halo signs. It's consolidation and ground glass opacity surrounded this foci of consolidation. What about morphological verification? Expert opinion, typical case that have a characteristic picture and respond to steroid therapy at dosage more than 20 milligram of prednisolone per day can be diagnosed without resorting to a lung biopsy, if other possible causes are excluded. That's why also the response for corticosteroid therapy is a very important factor for confirming about COP. But I told about this clinical case with new diagnostic of COP in 3 months, we changed diagnosis to lung carcinoma. So COP treatment included prednisolone at a starting dose 0.75 up to 1.5 milligram per kg duration 1-3 months, and relapse after discontinuation of corticosteroid therapy from 30 to 50% happen. And also in our clinical experiment confirming about the case of relapse of COP. Acute interstitial pneumonia. 2% amount in the idiopathic interstitial pneumonia. Affecting any age. Acute onset of disease has a feature of respiratory virus infection. Symptoms of acute respiratory virus infection, arthralgia, myalgia, chills, and dry cough. By the way, it's, for my opinion, that virus infection in case of acute interstitial pneumonia, it's a very important trigger. And now we have got experience treatment with patient with a new coronavirus infection with acute respiratory distress syndrome. It's confirmed our conclusion about the crucial role of viruses in this dramatically course of acute interstitial pneumonia. After symptoms of acute respiratory virus infection, Patient have got a progressive shortness of breath. After 14 days, patient have got a acute respiratory failure, symptoms of acute respiratory distress syndrome. Auscultation diffuse inspiratory crackles. And due to computer tomography, you can find diffuse lesion of the parenchyma, decrease in transparency of the type of ground glass opacity, zone of high density consolidation in the posterior basement section against the background of ground glass, thickening of intralobular partitions picture of the crazy power. In this case, you can see the example acute interstitial pneumonia and consolidation. This diffuse of ground glass opacity, and this the total involvement lesion of the lung, ground glass opacity, thickening of the walls is like a crazy pattern. By the treatment, but according to the experience of South Korean physician, an American author, after mini thoracotomy and urgent biopsy, patient was treated by pulse therapy of methylprednisolone, 1 gram per day, 3 days, which then prednisolone 1 gram per day, and plus protective non-invasive ventilation with low tidal volume, 6-8 milliliter to kg, and the high end is expiratory pressure. And highest survival rate. But so, frankly speaking, now after experience for treatment patient with new coronavirus infection, for my suspicion, it is the same acute interstitial pneumonia. It's a virus disease etiology, and virus. For example, this confirmation new coronavirus. How can we treat? Also use a pulse therapy of methylprednisolone and a blockade of interleukin-6, tocilizumab, polakizumab, and also non-invasive ventilation. But in case of progression, it's mechanical ventilation and ECMO, extracorporeal membrane oxygenation. Okay, a few words about smoking-related interstitial pneumonia. Discriminative interstitial pneumonia, 5% among idiopathic interstitial pneumonia. And 90% of patients have got a long history of smoking history. Yeah, the name was given due to presence of desquamation of cell of hyperplastic alveolar epithelium and macrophages into the lumen of the alveoli. The onset of the disease is gradual, slow, progressive dyspnea, dry, and productive cough, infrequently thoracolgia, hemoptysis, weight loss, low-grade fever in 25 to 50% symptoms or watch glasses, and the basilar inspiratory crackles. In case of DIP, you can find accelerated erythrocyte sedimentation rate up to 50 milliliter hours, increased blood lactate dehydrogenase at total immunoglobulin G level. 30% of patients have got a moderate restrictive changes on spirography investigation. And alveolar lavage detect 20% eosinophils, 30% of neutrophils, and increase in macrophages with the inclusion of brown pigment. Radiological features of DIP, diffuse ground glass opacity, correlative histologically with the partially homogeneous intra-alveolar accumulation of macrophages, thickening of alveolar septa, bilateral symmetrical basal and peripheral patchy and diffuse, irregular linear opacity, and in 50% patient detection microcysts. On the slide you can see ground glass opacity, reticular abnormality, macrocyst, and treatment: smoking cessation, systemic corticosteroids, half milligram for kg for 4 weeks, with subsequent decrease of dosage. Glucocorticoids are effective in 80 to 90% of patients. 5-year survival rate 90%. And last, respiratory bronchiolitis associated with interstitial lung disease, usually seen in young middle-aged patient with an average smoking history 60 pack years or more. Men are more affected than women, with a ratio 2 to 1 male to female. Onset present and progressive dyspnea and chronic cough. At clinical examination, inspiratory cracks are had in the up to 50% of patients. Digital clubbing is usually absent. Patient with mild symptom reveals a moderate reduction in carbon monoxide transfer factor, and patients with severe symptoms have more significant reduction of it. Lung function tests in patients affected by RB-ILD show both airway obstruction and restriction. Natural history of the disease is not available because of the low number of cases, but progression to dense pulmonary fibrosis has not been described. Nevertheless, smoking cessation determines a clear improvement. Higher resolution CT scan features are ground glass opacity, correlated with macrophage accumulation in alveolar duct and space, fully defined central lobular nodules, compatible with peribronchial expansion of intraluminal infiltrate, mostly diffuse distribution. Other features related to smoking: bronchial wall thickening and moderate central lobular emphysema. In this slide, you can see much better in this slide, in the central lobular nodules, maybe in cysts, ground glass opacity. Because of an overlap in clinical imaging and histological features between RB-ILD and DIP, there are considerably different degree of severity of the same disease. In fact, DIP is more extensive form of RB-ILD that involve larger areas of the lung. Treatment is the same: to give up smoking. Treatment with systemic corticosteroid dosage of up to 40 mg lead to improvement in 64% of patients. Positive change persists only in 25% within the 9 months of observation. Thank you for your attention. And if you have some question concerning this topic, you should write down in chat, and then next lecture I try to answer Thank you for your attention, and we will see at the next lecture. Thank you. Goodbye.